Hello, everyone. Welcome, and thank you for joining the 21st webinar in our Pandemics and Society series. Today's webinar topic is African Countries Struggle to Contain Mpox Amid USAID Cuts. I'll now pass it to our moderator, Wilmot James, Senior Advisor to the Pandemic Center and Professor of the Practice of Health Services, Policy, and Practice at the Brown University School of Public Health, to begin today's conversation. Wilmot?
Hello to everybody. Good morning, good afternoon, good evening, and a warm welcome to our discussion here today. So to start, to remind everybody that on February the 25th, 2025, the World Health Organization's Director General Tedros reaffirmed that the ongoing Mpox outbreak remains a public health emergency of international concern. According to the WHO, in the past 12 months, 22 countries across Africa have reported close to 22,000 confirmed Mpox cases, including 81 deaths. The three countries with the highest case totals have been the Democratic Republic of the Congo, the DRC, Burundi, and Uganda. Clade 1b Mpox, the recent variant of concern, has seen great international travel-related spread spanning Brazil, China, Sweden, Thailand, the United Kingdom, the United States of America, France, Belgium, Germany, India, the United Arab Emirates, and more. In the DRC, a lack of USAID funding has greatly impacted the accuracy of Mpox testing, while ongoing conflict is exacerbating the spread of the virus and reducing the access individual citizens have to healthcare. Mpox detection and treatment in the Eastern Congo has been severely disrupted as Rwanda-backed M23 rebels advance, forcing hospitals to shut down, patients to flee, and vaccine supplies to run short. A new so-called APOBEC3 mutation found in clade 1a Mpox was discovered in the DRC, sparking concerns of increased transmissibility of the virus. Meanwhile, Burundi has recently reported significant progress in fighting Mpox, with a 95%, quite a dramatic drop in cases since the peak in October 2024. To discuss the current Mpox landscape, past lessons in the response, and potential next steps amidst US funding cuts, we are very fortunate to be joined today by two panelists with deep experience and understanding of the issues at hand. So first of all, welcome to Dr. Richard Magisha, who is the field coordinator at the Uganda Public Health Fellowships Program at the Uganda National Institute of Public Health. And we are also really honored to be joined today by Dr. Ricky Romanik, a distinguished senior fellow of global health security at Brown University School of Public Health. And to mention that Dr. Romanik previously served as special assistant to the president. This is President Biden, and Deputy Director and Chief of Staff in the Office of Pandemic Preparedness and Response Policy at the White House. So thank you very much for joining us today. We will start with some initial questions, but we'd like to ask our viewers to please feel free to utilize the Q&A function so we can answer your questions later in the discussion. So let's start with the following question. If I can pose it to both panelists, but just to start off with Richard, to talk about how the reduction in USAID funding, to mention what are the most immediate gaps in Mpox response efforts in affected African countries would have to be plugged as a result of that reduction in USAID funding.
Thank you very much, and good morning, good evening, everyone. So usually for any outbreak response, we know that all the pillars need to be fully engaged. So quite I can say the gaps will be in all the response pillars, but to point out by prioritizing the first critical gap would be in surveillance. And from the African context, the big gap has actually been on community-based surveillance. We need to involve the community health workers, the VHTs, the village health teams, who are these grassroots foot soldiers, to be more involved in Mpox response. So this is already a gap, and it will even be more glaring with funding cuts. Next is about vaccines. We know that there is an urgent need for vaccines. This is going to be, we believe, could be a game changer for the African continent. But of course, with the dwindling resources, we will also see gaps in this vaccination availability at the African continent. And then laboratory capacity. We already need to decentralize laboratory testing and even curative services. So we will see also more gaps here in terms of decentralization, because without decentralized testing, then we will continue to see delayed detection. And also to mention is about the risk communication and community engagement. Like this Mpox disease is actually associated with stigma because of its link with the sexual transmission. And looking back at the history of even HIV, so there is a lot of stigma, and we need to engage the communities, enhance risk communication, and involve the communities in the fight. I think that's when we shall be successful, when we involve the community in general. So we will also see gaps for sure. They are already there, but these gaps are likely to even be more glaring amidst the funding cuts. Over to you, Wilmot. For now, that's it from me.
Thank you very much. I'm particularly interested, just as a follow-up question, on the question of local health authorities, what role they play to mitigate the impact of international funding. And if I can just ask you to address that question, and then I'd like to turn to Nikki for the next follow-up question.
In terms of local health strategies, first of all, we realize that, of course, donor funding is not sustainable, and we agree. And generally, talking from the African context, there have been efforts over time that started. Looking back, starting with the most notable is the Abuja Declaration of 2001, where they said member states of the African Union need to at least allocate at least 15% of the national budget to health spending. But of course, the progress has been very slow, with most African countries actually only even not reaching half of that 15% target. So we believe actually what will be sustainable and the mainstay strategy is increased domestic funding. However, in the short term, especially for this Mpox and other outbreaks, there are a number of innovations. One is we are trying to see how to optimize resources. For Mpox, for example, we are looking at alternative models. In Uganda, for example, since the inception of the epidemic, we realized that all Mpox cases, regardless of severity, were being managed in health isolation facilities, health facilities, which is resource intensive. However, now there are guidelines that have been completed of home-based care. We did this with COVID-19. and we can do it even with mpox. So this home-based care for non-severe cases, if we're rolled out, we believe we could optimize allocation of resources. Next is also integration of care models for outbreaks. For example, in Uganda currently we have 3 outbreaks concurrently. We have Ebola, we have mpox, and we have Crimean Congo hemorrhagic fever. These are viral hemorrhagic fevers, basically, and mpox. But it's the same response teams that are in surveillance, contact tracing. So what we are doing is to integrate these responses. That will also optimize responses. However, of course, this is a double-edged sword, as responders may tend to lean on one. As we have seen, they have actually leaned on Ebola and neglected mpox. And that's why we are seeing so many cases coming up. So basically, that's what I can comment in terms of alternatives to that. Yes, over to you, Wilmot. Thank you.
No, thank you very much, Richard. So Nikki, you've heard Richard's characterization of what the gaps are and what kind of initiatives are being prioritized on a national and regional level. We understand, obviously, what the impact of the USAID cuts have been to the resource flows. So there's that. And so the question to you is, what can the global community do in the light of the resource gaps that exist, and also to support both, in the case of Uganda and the region, their capability to actually execute on their priorities?
First of all, hi, Wilmot. Thank you so much for having me today. It's wonderful to be here with you and Richard. So I would like to start off by just mentioning one more gap, unfortunately, that is directly related to USAID funding. Unfortunately, sample transport is also significantly delayed, which leads to also a delay in testing results and will lead to additional spread of mpox cases. Given the unprecedented time that we are in, at least I call it unprecedented, I think now is the time for each of these countries to rapidly step up. Of course, we would have liked this to continue on a gradual pace, and we would have preferred to continue training people in country, but now that everybody is facing this unprecedented time, these countries will now have to kind of go full force when it comes to their domestic response efforts. I also think that innovative funding, such as public-private partnerships and other funding that's outside of the federal government, should be looked at. And I know that Africa CDC is already very much looking into it, but now is the time for each of the countries to invest in their own domestic preparedness and response models, which I know that many of the countries are already starting those conversations or are very far along in those conversations.
So thank you very much for that, Nikki. Could you just elaborate on what can be done immediately, what would be sort of short-term goals, and what would be longer-term goals in terms of boosting capability?
So I think immediately, when I always think of this, and this is something that some of the countries have actually already done before all the cuts happened, you need to use the resources that you have, because all of the resources have either been frozen dead in their tracks or are not coming. So because of that, your resources many times are people. We need to try and train up as many staff as we possibly can and healthcare workers to do the work, educate them and communicate to them so that they are not fearful, and teach them the basics of response. One of the most important things I've seen flip a response quicker than anything is educating locally trained staff on how to do case investigation and how to work in a lab. And that is something that we continually try to do. I think each one of us has probably taken part of one of those exercises a few hundred times in our life. But I think now is the time for the countries to expand on that as quickly as possible with as many locally trained staff as they possibly can, and bring on new workforce if possible in some of these countries. The village health teams are already in place and have been in place for a very long time. Try to expand upon those teams and try and grow them and try to educate them on more than one capacity. So what do I mean by that? Trying to educate them on risk communication, contact tracing, but then also cross-train them in laboratory, taking laboratory specimens and laboratory transport, so that they're able to do more than one thing. Train them on how to give a vaccine when vaccine supplies increase so that they know how to actually administer the vaccine. That brings up another thing. Try to get as much vaccine in country as possible and try to stand up as many vaccine campaigns and access to vaccine as you can in areas that have increased transmission.
Thanks, Nikki. So, Richard, you've heard Nikki's comments in terms of what is possible that can be done. So if you can just comment on that just from where you sit, because it's very clear that there's a discrepancy between laboratory confirmed and clinical case numbers. It's suggesting underdiagnosis. So how does one deal with that? And secondly, the gold standard genomic sequencing capability seems to be inaccessible in many affected regions. And so, what kind of practical instruments can be used in order to improve detection rates?
Okay, thank you. In terms of laboratory testing and the discrepancy between suspected and confirmed, I agree there is really under detection. And that's why the strategy is actually to decentralize testing, because in these African countries, the key issue is that the testing is available at the national level, but limited at regional and district levels. So it's to increase the capacity. And like Nick was saying, even the training on sample collection, sample transportation, because the quality of the samples also will contribute to the diagnostic yield. So we need to increase capacity, decentralize diagnostic services. That is one. Two, we also need to continue the supplies. And I think the supplies are also an issue, but that will come in within the capacity. But for genomic sequencing in this context here is not readily available now. For African context, the mainstay really will be PCR testing. But if we can decentralize this, it will also improve diagnosis. Yes, we need to decentralize the PCR testing. Perhaps to add to that is that we can combine, because in each country there is a specialized lab or one or two that can actually do genomic sequencing, the reference lab. So we could actually combine the reference testing, those samples of mpox which are highly suspicious to be positive and they turn out to negative can be shipped to the reference labs to further improve diagnostic yield. So combining these two in our context will actually improve diagnostic yield without necessarily affecting turnaround times, because the turnaround time is one of the things that has really deteriorated the response, delaying timely responses. Thank you.
Thanks, Richard. Just a follow-up question. Burundi has succeeded in getting the case numbers to drop quite spectacularly, right? It's a 95% drop. And so here seems to be a good exemplar in terms of how to deal with this. Could you comment on that? Which other factors in your estimation contributed to the success, and do you think it's possible to replicate that?
Thank you, Wilmot. And I think Burundi is a very good example of what we are talking about. Basically, what has contributed to the big significant decline is two factors that have changed. The first and the most important is at the inception of the epidemic in Burundi, they had only one testing lab in the country. And what that caused, the turnaround time was very long, so many days. Cases were staying longer in communities and sustaining community transmission. Cases were being mixed with non-cases and also having those nosocomial infections. So all of those were actually propagating transmission. Now, what Burundi did is to actually decentralize testing. And Burundi actually leveraged on the already existing HIV TB infrastructure, PCR testing labs at the district levels. So in Burundi, at every district, they decentralized, and every district was now able to actually test their samples. And recently now, their turnaround time has reduced to less than 24 hours. And actually, 90% of the cases in Burundi are identified and rapidly isolated in less than 24 hours. And this is really a very good success story. So this proves that actually the rapid responses, timely, and this especially decentralized lab testing really has been a game changer. Now, the other factor, of course, has been they have improved their case management strategies, and cases are being managed optimally. Because in some countries, you realize cases are being discharged when they are not fully healed and they are still can transmit. There have been gaps. So Burundi, first and importantly, has been decentralization and reducing turnaround time. Secondly, it has been to optimize case management. All of these have reduced the cases staying shorter times in the community, and this is how they have managed to break the chains of transmission. Thank you, Wilmot.
Thank you very much, Richard. So colleagues and participants, Burundi is one of the 10 poorest countries in the world. It's worked very closely with the Africa Center for Disease Control, which provides technical support to 55 African countries. And of course, the WHO plays a major role together with UNICEF in terms of global agencies. What we have here is a success that can be replicated, and we really just appeal to the global agencies to help support, rolling that out as best practice and so on. So that's a really, really, really positive development. If we can just widen our horizon a little bit to speak about vaccines, and this is a question I'd like to put to Nikki about what assessment and the reading is in terms of the availability, distribution of vaccines to stem Mpox. It's a question in one of our participants in the chat box asking the same question, which is, how do we maximize the impact of the vaccines that we have? And is there any way of accelerating increased availability and distribution? A big question, but a key question. We have a vaccine, right?
We do. We have a couple.
We have a
actually.
vaccine. Yeah.
We actually have more than one. So when this outbreak started, we, at least in the United States, we had been preparing for it for many months. When it was a slow bubble at the beginning of cases, and people really weren't focusing on it like they should have. And so because of that, we were able to put some things in place. Now, my concern is I don't know where those things now sit now that I have left the administration and there's a new administration. But of the things, one of the things was a donation of vaccines that spurred significant donations from other countries' stockpiles as well. So a lot of vaccines have been donated. not many have been administered, unfortunately. Having a vaccine donated versus having the entire logistical coordination for planning and administering a vaccine in a country is completely different. So I think at this time, as much as possible, they need to try and get vaccine access to as many locations that are considered hotspots that have ongoing human-to-human transmission. That being said, we are specifically in DRC, we are in a place where it's extremely dangerous right now. And I can tell people to vaccinate, 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 but there are security issues right now with the invasions that they're dealing with. And unfortunately, most of the places that have been invaded are also the same places that are hotspots for Mpox transmission right now. So not the best news at all. What can we do with vaccine that we do have? There are options to just give the first dose, of course, and in vaccine constrained situations, that is a recommendation that can be used. There are other options to also give it intradermally. I do not believe that that is currently an approved method of giving the vaccine, but that can be looked into to see if that approval could come through. But there are options. Unfortunately, all of those require resources of people, healthcare workers, educating those healthcare workers to teach them how to give the vaccine, getting the vaccine supplies to the areas where there is the most conflict. Currently, right now, it's not even possible in most of the areas to get vaccine supplies there. So there's a lot of work to be done. It's not that they're not trying, it's that it's an incredibly dangerous environment. So we should just focus on what we can do. Try to get vaccine to the places that are safer. There are vaccine access issues in places that are safer, unfortunately. So try to get one of the vaccines to those locations as much as possible to try and stem some of the transmission. And focus on if we need to do intradermal dosing and what that entails, because it's going to be a regulatory approval that may take some time. And Richard, please feel free to add anything more since you are in Uganda.
Thank you. I think you have said it all, and I think it just comes back to resources, resources, resources. And I think this is a question that we'll ask about what has the global solidarity. We need to improve that. Otherwise, we see the most affected areas will continue to suffer. Other countries are maybe stockpiling vaccines where the transmission is high, there are no vaccines. So it comes back to global solidarity. I think this is a question of, looking from the global lens and trying to improve this global solidarity. It's doable, and otherwise, I can see that there is a tendency to reverse the gains with this issue of each country on their own and all this. I think we need to put our resources together and improve the global solidarity. But we'll come back to resources, resources, resources. Thank you.
So thank you for that, but I'm going to be very direct. The political context is, in fact, not just less than ideal, it is awful, right? So we've got an ongoing war there, and the question is, how do you deal with an epidemic in a wartime situation, and who's responsible for at least dealing with resolving the issue there? The African Union, its purpose, it has a peacekeeping mission. It has a political responsibility for the continent in order to do as much as possible to resolve political conflicts. And so I must say, I like to appeal to the African Union. It's got a new leadership to really focus on this question. Firstly, and I say that as a former member of parliament from South Africa, this is a call to actually execute on that mission. Secondly, a lot of the problems in the DRC in terms of vaccine availability has to do with slow approvals. And it's a political problem. Just slow action on the part of the DRC government So I'm going to call again for the DRC government to, in fact, do everything possible to have greater efficiency in order to deliver vaccines that exist. These, needless to say, these are life-saving technologies, and if we don't deliver them, it's not a technical or scientific failure, it's a political failure. And so we must do everything possible, because what we're creating is a hotspot for transmission. The DRC is a very big place. It's geographically difficult, we know. So I do believe that it's necessary to resolve the political issues. We can't do that. The science community can't do that. The public health community can't do that. And so that context has to be transformed. And so I just wanted to make that very direct appeal from this, because otherwise it makes the public health community's work very difficult. If I can just step off that for a second and turn to more scientific questions around detection of the mutation APOBEC3, APOBEC3, I guess is a way to pronounce it, that's in the clade 1A mpox, which has raised concerns about increased transmissibility and severity. So, so the question is, what implications does this have for public health interventions? If I can ask Nikki first to respond to that, please.
Absolutely. As Wilmot said, and I will say before I answer this question, thank you for making that plea. As a scientist, it is really hard to watch and not be able to do anything. So I completely agree with what you just did. Thank you. So as far as what we're seeing in clade 1A, and of course, we didn't have a clade 1A or B 2 years ago, so now we have a clade 1A that is not, it looks like it may not just be zoonotic transmission. What we're seeing is that with this new mutation, we could see sexual transmission. Sexual transmission has been identified in clade 1A, which means instead of just zoonotic, we also have the same sexual transmission in sexual networks as clade 1B and as clade 2B. But what we are seeing that has surprised me, and what lets me sleep a little bit at night, not a lot, but a little bit, we're not actually seeing the severity, and we're not seeing deaths increase in clade 1A via sexual transmission. However, I do caveat that with we do not have enough specimens and or patients to make that final decision. This is just what we're seeing off of the patients that they've seen. As of January, many of the people that were working on this had to leave the country because it was not safe to be there. So this is a very small pool of patients that they have kind of documented what they've seen, and they need to see a lot more patients. They need to have a lot more specimens sent to labs to try and figure out what's going on. They need to have some case investigations to figure out if it was sexual transmission or if it was zoonotic transmission. And they need to focus on treating the patients and seeing how the patients evolve. So far, having this mutation is not showing the worst case scenario, but we really don't know. This is a watch and see type situation.
Apologies. Thank you very much for that response, Nikki. So I wanted to just go back to the DRC again, because the other matter that's going on is the displacement of over 2 million people, and then the shutdown of hospitals in the DRC area, which obviously poses risks. And I just wanted to ask Richard to comment on that with regards to the DRC, and of course you in Uganda, so you know what the situation is there as well.
Thank you very much. Definitely, the DRC situation is we're already in an mpox emergency, and the conflict makes it only a more complex emergency. So, like even Nick has said already, we will see that some prevention measures like vaccinations are disrupted. We in DRC, even there are reported cases where the confirmed cases in isolation had to flee the hospital when they are still active. So that tells you about the risk of community transmission that is going on. So what I can comment about the DRC situation is actually the real burden of mpox is masked by this conflict. And what can be done is probably to try and involve the local communities to, probably the community-based surveillance, strengthening that could bridge the gap between the testing so that there are many, as the suspicion is so high and at even the community level, that would probably improve the detection, but also other innovative approaches like probably mobile testing and point of care testing to improve the detection in these complex situations would probably be more appropriate, but also the turnover of healthcare workers. You need a stable workforce. Healthcare workers are also freeing. The turnover is very high. Maybe the governments are changing from government to rebels and all this, and not the same health workers are involved. So there is that need to continuous build capacity. And I think for DRC, really, the issue is we need to respond as a more complex emergency in view of the unique circumstances. But for the neighboring situations, of course, there is a need for cross-border also collaboration because the neighboring countries in the East African region, especially, need to heighten surveillance, especially at the border districts. And here, especially, they need to do active surveillance. Passive surveillance won't be enough. It won't be sufficient. They need to heighten surveillance, preferably active surveillance in this situation. Back to you, Will.
Thank you. Could you just elaborate on the kind of hotspots, if I can use that term, when it comes to cross-border migration? I mean, the DRC's borders are long, considerable. There are a whole range of countries, right, that would border on that. What are the most vulnerable areas? And do you see sort of a focus on those hotspots, drawing on, say, for example, the Red Cross and Doctors Without Borders and a sort of global support agencies around that?
Thank you for that. And I think we even did some population movement mapping to see what has emerged is that actually most of these, they use porous borders. And that has further, made the situation of surveillance at the points of entry challenging. And we also have fewer designated points of entries with all the capacities to do surveillance. We already have gaps actually at the POEs, points of entry. So then this is further complicated by the porous borders, which are more numerous, and there is not so much enforcement. I think it is Rwanda which has really done so much in enforcing using the designated points of entry, but elsewhere it's too porous, and that's the situation. But I agree with the partners paying attention to this and doing more screening. And probably people come also when they are intubating, so that complicates. Do we need to quarantine them for some time before assuming they are intubating? This needs a lot of resources, and it's something to look into further. Whether it is cost effective, it's something that can be done to enhance the detection and minimize the risk of cross-border spread.
Yeah, no, thanks very much for that. I mean, you raised the issue around the responsibilities of individual countries around that regional cluster. the role of regional associations and the role of continental associations and bodies, and then global ones. And I don't mean to be vague about this. If you're dealing with hotspots, what's required would be regional support from the Africa CDC to deal with it. There would have to be support from the WHO to deal with this. When it comes to migration patterns, the International Organization for Migration, which is based in Geneva, to help with population mapping. And then really to get those things under control, you need to be able to mount resources and people with capability around those hotspot areas. That's what would be required. It's a regional strategy. No single country can tackle it. And so one would imagine there's a realization that you need a task force to deal with that particular issue. I'd like Nikki to comment on that as well.
Sure, happy to. I think the way that I look at this and how you kind of can combat this, not just now, but also what you can do in the future and kind of the things that we've learned about the situation. I think it comes down to risk communication, resources, and training. All of that is really in a task force. That's probably the best way to describe it. If you build up these task forces that have these abilities and you pre-position resources, that's the dream, is to pre-position them. And then you keep building out decentralized testing, like Richard mentioned and keep the areas warm that had decentralized testing in the last outbreak. I think you are not starting from scratch. And in this situation, in this outbreak specifically, I have noticed a waxing and a waning of how far we've come. We come so far, and then unfortunately, we are kind of punched in the face with this challenge, and then we start back here. And that just keeps on happening with this outbreak. So in order to kind of get ahead of it, we just need to kind of double down on in-country efforts, and that can only be done through the political leadership in each one of those countries. And Africa Union and Africa CDC, I know, has been working very hard on working with the political leadership, but each country's political leadership needs to get behind getting all of these things in place and pushing these things forward, pushing vaccination forward, pushing decentralized testing forward, pushing risk communications out from their political point of view. So those are just a few of the things.
Yes, no, thanks very much for that. I mean, I'm aware of the fact that the Africa CDC has focused on it. It does have a special focus on Mpox. Dr. Ngogo, who leads that team, his leadership is strong. But the Africa CDC needs big support. And in the end, the Africa CDC is a technical support agency, and it's individual countries, as you mentioned, that require to do what they can. And I'm not saying that they're not, but I think there's a real need to step up that effort, especially in the light of the funding cuts. So just to applaud your comments, Nikki. So if we've heard that financing for the health security requirements heading into the future is going to contract by a considerable percentage. I've heard a percentage of 40% contraction in global health financing under circumstances where there's increased demand. And therefore, what we are looking at right now is going to get worse, actually, certainly in the short run. And so what it does, it raises questions about the word that's used often is innovative financing models. So I just wanted to hear your reflections, just starting with you, Nikki, about where do you think that global context is going to go? And then to think we need to have a real think about Africa's place in that, given its current vulnerability. Is that a fair question to ask?
Yeah, I'm really, my answer is not a happy one. I'm really concerned about what the financing is going to look like a month from now, 2 months from now. I think you're right. It's going to get it's just going to get worse before it gets better. And I think it's going to stay worse for multiple years, unfortunately. But because of that, we need to look at alternative ways for funding. And I know that there are groups that are spending hours and hours on looking at what alternative funding could be in this type of an outbreak. A couple of things that have happened in the past that worked. Gavi's first response fund, which allowed for advance purchase agreement for Mpox vaccine. That was at its time an innovative funding mechanism. Now we need to come up with more innovative funding mechanisms. We need to pile on the innovative funding mechanisms because there isn't going to be, and this is just Nikki's opinion, I don't think there's going to be a philanthropy that's going to fill all of the gaps financially. And so we need to figure out how we can be a little bit more work harder and smarter, I think is probably what we need to do. So the innovative funding needs to maybe come from places that it's never really come from. We've always had nonprofit support, but we haven't really had strong public-private partnerships, and we haven't had private sector itself specifically lead private partnerships. So I would like to see private sector step up in this time and in this need and try and lead partnerships, partner with NGOs, partner with leadership in countries, partner with Africa CDC. I would like to see them really try and hone in on how they can help best. So we just need to be a little bit more innovative in the future, because this is going to last a while.
No, thanks for that. So people often speak about public-private partnerships, and they sound good, but getting them working and in place is not easy. But it's possible. It's possible. We have to be open to what the private sector has to offer, which is quite a bit. It has resources to offer, people, expertise, systems, technologies, and different companies can contribute different things. And it doesn't just have to be with money, and it has to be a partnership. That is to say that there's mutual benefit. So there are quite a number of initiatives underway on the African continent. We just need a lot more of that. We were talking earlier about the interest on the part of individuals on the continent in technological innovation. Africa is a continent with young people with a really keen interest in using modern tech in a whole variety of ways. There's been innovation on the continent in terms of how to use applications for banking, for example, increasing interest in those apps for looking at digital health systems and developing innovation. So just to emphasize, there's enormous potential that you can unlock. So to say thank you very much for that, Nikki. Richard, could you speak about the same things about how individual countries, maybe with a focus on Uganda, can develop innovative practices in what we refer to as resource-stressed environments, including when it comes to laboratories, for example. Laboratories are expensive to build, and they're very expensive to maintain. And once you lose that ability in the longer term, then that capacity is gone, right? So we need, for example, really good labs that are not as expensive as the Rolls Royces of the world, but can do the job effectively as well. But just a comment on what governments, individuals can do in order to develop innovative practices. And then there's some questions in the chat I'd like to turn to in closing.
Okay, thank you so much, Wilmot. And I think Nikki and yourself, you have actually said quite most of it. But what I can comment is when you look at African countries, most of them have small economies and yet have bigger health threats. So this is one context that we are looking at. So if we are to say each country be self-reliant, I don't think this is a sustainable way to go in the long run. But like you were saying, partnerships, for example, the East African community could pool resources and invest in, I think this is already being done in Rwanda to look at some vaccine manufacturing as a region. So I think Africa and the Africa CDC is expected and is taking a lead on this. As a continent, as a region, can we pool resources and build the core capacities? This is the long-term solution. In the short term, I think these funding cuts have been unpredictable, unprecedented. It's challenging. It's a crisis. Probably we need to resort to short-term solutions like innovative models. How do we integrate this? Like now in Burundi, what they are doing, they are using the leveraging on HIV and TB infrastructure to also do integrated care models for the different diseases. So some of these, but to sustain them also, we'll come back to resources. But as I said, I think we need to build our capacities, but this is going to take some time. But I think with partnerships and continued support, we'll get there. But what I can say, I think some of these solutions may need probably further research into what works. For sure, it's a question at the mind of everyone, and there may not seem to be the most correct answer on how this will go forward. Over to you.
Thank you, Richard. So there's a comment in the chat that goes as follows: the regional approach Dr. James described was done well during the DRC Ebola 2020 outbreak with multinational meetings of border staff and partners. So thank you very much for that remark. Then there's also a comment that goes as follows: Richard has emphasized what is important for Africa, creating the enabling environment for community surveillance. And that is what our governments have to do before asking for vaccines. Africa has the basic capacity. It has the experience and the human resources and capacity to mount great surveillance. We just need our governments to prioritize the efficient use of budgets to ensure reliable surveillance. Thank you for that comment. That's a great comment. Let me just say, for those of you who are not entirely aware, Africa's health system is run by nurses and community health workers, and of course with physicians, but it's essentially a nurse, community health worker-driven health system continentally. And that's an extraordinary thing, actually, in terms of the capability that the continent has. And so this comment about community surveillance is central. There's nothing like a community health worker for sniffing out a problem and spotting it, right? Something unusual is going on here. Let's look into that. There's nothing like, so the training that Nikki was referring to in terms of the community health workers and nurses as part of a surveillance were quite right. So let me just again ask Nikki and Richard to think about what kind of message you'd like to leave in terms of just a lightning set of comments about the key point you'd like to make about the lessons we've learned from the Mpox outbreak that we currently have, and what would be the most immediate urgent things we need to focus on in order to contain the outbreak and get it under management. Let me turn first to you, Richard.
Thank you. I think what needs to be done, what we realize where there has been sustained transmission, basically we have been behind. The outbreak has been ahead of us. So to be ahead of the outbreak, we need to rapidly respond, timely detection, and this will require improving the community-based surveillance from the African context. It will require decentralization of curative and laboratory services, which will really improve early detection and prompt responses. This is what will be required. But of course, what is in the background, resources. This needs to be prioritized as a public health emergency of global concern, and that needs more resources. Otherwise, we'll continue to see cross-border spread everywhere on the African continent and beyond. Thank you very much.
Thanks, Richard. Nikki?
All right, I'll try and keep this quick, but I have a lot to say, so I'll try and be quick. I think what we've learned a lot of different things that went well, and we've learned a lot of different things that aren't going so well. And there's a lot of different scenarios that we can't control. But what we can control is we can control trying to get this a priority in each one of these countries. There are a lot of things that these countries are dealing with. It's not just Mpox. There's cholera, there's measles outbreaks, there's many other infectious diseases alone, and there's also conflict. So we just need to try and explain and show why this is one of the priorities that they should, going forward, prioritize. And I think some of the countries have. Burundi did immediately, and that's why we saw an incredible response. Burundi, what they did with their healthcare workers and the ability that the healthcare workers had to identify a case and then isolate the patient at a rapid speed is one of the things that stemmed that outbreak. And it happened so incredibly fast. So fast, I think it was actually written about that they would spot and they would rapidly refer to Mpox treatment centers, and it stood up within days. So those types of innovations need to be held on. That's a lesson learned, I think, for us. One of the most important things I've learned when I've done outbreak response, I could list off all of the things. We need to decentralize, we need resource. I could do all of that. But one of the things I've learned is the moment there's an outbreak, talk to the people in the country and ask them what exactly is going on and what they need. We can send all of the things in the entire world that we think they need, but if we talk to the countries and we talk to the healthcare workers and the nurses and the response coordinators and we ask them exactly what the landscape is and what they would prioritize, I think we get much further significantly faster.
Thank you very much. So there are some comments in the chat, and I'd like to read the one that I think is entirely appropriate given what has been said, is that the message to Africans, this comes from an African, to build on her strengths in surveillance and fund the enabling environment for trained experts to function effectively. That would be the greatest thing that can be accomplished. It's said here that we are placing too much emphasis on aid and support. I think that's right. We need support, but if we use our local funds well, we can almost do without aid. Well, I'm not quite sure about that, but I do think that combination, I think, is right, and the emphasis has been placed on mobilizing resources for what African countries are already very good at, in fact, exceptional in many cases, is the right message to end this end this webinar. And with that, I'd like to thank our panelists, Richard and Nikki, and to everybody who has joined us today for such a productive, timely, and very robust discussion. Thank you also to our team at the Pandemic Center who helped to put this together: Bentley Holt, Michael Mitchell, Leah Lofgren, Amanda Kogan, Carly Gasker, Andrea Ulig, and Anne Wang and Alice M. Finally, if you would like to share this event with anyone who was unable to attend, the recording will be posted on the events page of our website. You can also find recordings of all other webinars there. Please follow us on our social media accounts, the handles of which are on the screen, to learn about all of our events and future webinars. Please reach out to our email address with any questions and suggestions for future webinars in our Pandemics and Society series. Thank you. We are adjourned. Please be safe, be healthy, and stay engaged. And with that, enjoy the rest of your day and evening. Bye-bye.